PCOS and biochemical correlation. Polycystic ovarian syndrome is a condition where we find in the ovary multiple tiny cysts about 2 to 9 mm in diameter arranged in the periphery of the ovary like a necklace, and it has caused the tremendous biochemical problems in the body. To diagnose the conditions, either oligoovulation or anovulation, hyperandrogenism, and polycystic ovaries. Out of these three, true criteria has to be present. Coming to the different phenotypes A, B, C, D, this has been based on phenotype A, androgen excess plus ovulatory dysfunction plus polycystic ovarian morphology in the ultrasound. Phenotype B, androgen excess plus ovulatory dysfunction. Phenotype C, androgen excess plus polycystic ovarian morphology. And phenotype D is ovulatory dysfunction plus polycystic ovarian morphology. Screening and diagnosis of PCOS as recommended by the International PCOS Network 2018. It has been diagnosed by the history of the irregular menstrual cycles and ovulatory dysfunction, biochemical hyperandrogenism, clinical hyperandrogenism, ultrasonography pictures of polycystic ovarian morphology, anti-Mullerian hormones. This assay is more accurate in the detection of polycystic ovarian morphology. Some ethnic variation are also possible, as for example, say for the Southeast Asian women, there is tendency of increased central adiposity, insulin resistance, diabetes, metabolic risks, and acanthosis nigricans. But today's lecture is on biochemical correlation, so we will discuss only on the biochemical milieu. So first of all is the how to establish the biochemical hyperandrogenisms as per the recommendation by the International PCOS Network 2018. There are three types of recommendations are there. The most strong one is the evidence-based recommendations. Number one recommendation is calculated free testosterone, free androgen index, or calculated bioavailable testosterone should be used to assess biochemical hyperandrogenism in the diagnosis of PCOS. Number two, high quality assays such as liquid chromatography mass spectrometry LCMS and extraction chromatography immunoassays should be used for the most accurate assessment of total or free testosterone in PCOS. Number three, androstenedione and dehydroepiandrosterone sulfate DHAS could be considered if total or free testosterone are not elevated. However, these provide limited additional information in the diagnosis of PCOS. Next is the clinical consensus recommendations. Direct free testosterone assays such as radiometric or enzyme linked assays preferably should not be used in assessment of biochemical hyperandrogenism in PCOS as they demonstrate poor sensitivity, accuracy and precision. Third recommendation based on the clinical practice points. Assessment of biochemical hyperandrogenism is most useful in establishing the diagnosis of PCOS and different phenotypes, where clinical signs of hyperandrogenism, especially hirsutism, are unclear or absent. Number two clinical practice points. Interpretation of androgen levels needs to be guided by the reference ranges of the laboratory used, acknowledging that ranges for different methods and laboratories vary widely. Normal values are ideally based on levels from a well phenotyped healthy control population or by cluster analysis of a large general population considering age and pivotal specific stages. Where androgen levels are markedly above laboratory reference ranges, other causes of biochemical hyperandrogenism need to be considered. History of symptom onset and progression is critical in assessing neoplasia. However, some androgen secreting neoplasms may only induce mild to moderate increases in biochemical hyperandrogenism. Reliable assessment of biochemical hyperandrogenism is not possible in women on hormonal contraception due to effects on sex hormone binding globulin and altered gonadotropin dependent androgen production. Number 5, where assessment of biochemical hyperandrogenism is important in women on hormonal contraceptions, drug withdrawal is recommended for 3 months or longer before measurement, and contraception management with a non-hormonal alternative is needed during this time. So after this establishment of hyperandrogenism, let us come to know what are the biochemical abnormalities caused by PCOS. It causes hyperandrogenemia, hyperprolactinemia, hyperinsulinemia, insulin resistance, hyperlipidemia, hypersecretion of LH, high serum estrogens, low serum SHBG, androgenic ovarian follicular microenvironment, low FSH, low serum progesterone, etc. So before going in details of this, let us have a recapitulation of this, the steroid biosynthesis. Not going into details of all of that, just look at this red colored areas. The DHEA is formed from 17 hydroxypyridinolenes, and by the 3 beta hydroxysteroid dehydrogenase, it's been converted to the androstenedione. Androstenedione also formed from the 17 hydroxyprogesterones by the 17 alpha hydroxylase. This androstenedione, in the presence of the 17 beta hydroxysteroid dehydrogenase, been converted to the testosterone, and testosterone been converted to is active from dihydrotestosterone by the 5-alpha reductase. Now this androstenedione and testosterone both are being converted to the estrone and estradiol respectively by the aromatase enzyme, and the estradiol and estrone are interchangeably converted by 17 beta hydroxysteroid dehydrogenase. With this background of this androgenic environment, let us proceed for the next part. Hyperandrogenism mainly by the ovary is contribute the most of the androgens, and partly from the adrenal and the systemic metabolic conversions. Ovarian thicker cells, they produce more amount of androgens under the influence of the increased LH stimulations, P450C17 enzyme dysregulations, decreased aromatizations, increased insulin level, increased androstenediones, increased testosterone, increased insulin-like growth factor 1 activities. And these androgens move from the ovary and as well as the adrenal glands. These high androgen levels ultimately goes to the systemic circulation in the periphery because of peripheral aromatizations. But as there is decreased SHBG, so unbound estrogen level become more, as well as the estrone level, the EON levels become more. So tonically there is an hyperestrogenic state, and this hyperestrogenic state causes increased sensitivity of the pituitary as well as increased sensitivity of the hypothalamus to cause increased GnRH pulse frequency. And this increased GnRH pulse frequency of the hypothalamus, they exert effect on the pituitary, where there is a preferential for the luteinizing hormone, and the amount of luteinizing hormone increases, making the less preferential for the FSH, and the LH-FSH ratio get altered. It is 2:1 or more. Because of this increased LH, again the thicker cells of the ovary, they causes more androgen. Also there is decreased aromatizations and decreased follicular maturations. This causes the excess inhibins. This also causes the inhibitory effect on the FSH, ultimately again altering the ratios. Now this excess level of the androgens, they are coming and getting secreted to the systemic circulations, and then they, as the result, the more amount of androgen in the systemic circulations, decrease SHBG and increase peripheral conversion to the estrogen, causing increased free testosterone and increased free estrogens. They are again causing the effect on the pituitary to promote more LH, and ultimately this effect also again sensitizes the hypothalamus to cause more GnRH release, and ultimately the same cycle go on. After this hyperandrogenism, let us come to the next important part of this PCOS is the regarding the biochemical part is the insulin resistance and hyperinsulinemia. And the most common cause of it in PCOS is obesity, mainly the central obesity. The central obesity that causes the increased insulin level and increased insulin resistance. We already come across that in the ovary that causes the increased androgen levels. Also in the liver, there is a decreased SHBG and decreased insulin growth factor binding protein 1. So there is again increased androgen level and hyperandrogenemia again becoming more. Insulin resistance is nothing but a condition where the body does not affect well to these insulins, and pancreas try to compensate by making more insulin, resulting in hyperinsulinemia. And to diagnose these conditions, we measure the fasting insulin. If it is more than 25 microinsulin per ml, we call this, as well as the ratio between the fasting glucose and fasting insulin. If it is less than 4.5, this has been diagnosed as insulin resistance condition. These compensatory hyperinsulinemia stems as a response of the pancreatic beta cells in order to preserve lipid and carbohydrate homeostasis in face of reduced insulin sensitivity. And this compensation leads to beta cell exhaustion and the genesis of metabolic syndrome and other comorbidities. To diagnose metabolic syndromes, the following 5 criteria: the triglyceride levels more equal to 150 mg per deciliter, HDL less than 50 mg per deciliter, blood pressure more or equal to 130 by 80 mm mercury, fasting glucose more or equal to 100 mg per dl, abdominal meaning the waist circumference more than 88 cm. 3 out of these 5 should be present to diagnose the condition of metabolic syndrome. And it has caused so many sequelae, some short term, some long terms. The short term is the obesity, menstrual abnormalities, anovulation, infertility, miscarriage, abnormal lipid profile, androgen excess, causing the acne, hirsutism, alopecia, insulin resistance, causing glucose intolerance, acanthosis nigricans, etc. etc. In the long term, it may cause the diabetes mellitus. Almost 15% of the patients they develop this. Endometrial cancer, very alarming because of the persistent elevated estrogenic effect. Dyslipidemia, decrease HDL, increase LDL, increase triglycerides, leading to hypertension, cardiovascular diseases, atherosclerosis. It may even go to the obstructive sleep apnea due to the obesity. It has been seen that the leptin and adiponectin have strongest correlation with free androgen excess in adult women with PCOS. In adolescent PCOS, it has been seen also that the PCOS offspring show inflammatory biomarkers MMP9 and S108 are increased, suggesting that these children may exhibit increased chronic low-grade inflammations. MDA, malondialdehyde, is an oxidative stress biomarker. This also is increased in the PCOS, increasing the excessive ROS activity. So in future, this can also be used as a biomarker for diagnosing the PCOS. So after knowing all these features of the diagnostic part of the biochemical correlation, let us come to the little bit of the therapeutic part of biochemical correlations regarding the PCOS. We know that weight reductions is the first therapeutic strategies of the PCOS, which causes the reduced adiposity, androgen levels reduce insulin levels, improve ovulatory functions, increase fertility, and reduction in the overall risk of the cardiovascular diseases. A mere 10 kg weight loss, there is a 40% decrease in the hyperinsulinemia and ultimately improvement of the whole condition. Coming to the pharmacotherapy, the most commonly used drugs are some insulin sensitizers like metformin, pioglitagens, etc. They causes the decreased hepatic gluconeogenesis, so ultimately causing the increased insulin sensitivity and changing the scenario. Statins, they also causes the decreased cholesterol synthesis and helping to make a good scenario. Gliptins, they causes the dipeptidyl peptidase 4 inhibitors, which is the ubiquitous enzyme responsible for degradation of the internally produced GLP-1. They also have a tremendous effect in reducing this insulinemia, insulin resistance, and then myoinositosis, they causes the increased SHBG, so there will be less amount of the free androgen, so less hyperandrogenism, so ultimately changing the scenario. Some newer treatments, the PUFA, the iron-3 polyunsaturated fatty acids, causing improvement by its anti-obesity, glycemic and hormonal homeostasis, anti-inflammatory, regulation of the adipokine productions, and enhancement of the endothelial function. Some more newer treatments like the sodium glucose cotransport 2 inhibitors, glucagon-like peptide 1 receptor analogs, they have been coming up. Of course, there are many out there, so I'm just mentioning few. So SGLT2 inhibitors, namely like empagliflozin, dapagliflozin, canagliflozin, etc. They inhibit the SGLT2 in the proximal convolutive of the kidney. As a result, there will be decreased glucose reabsorptions and increased urinary glucose excretions. So as the glucose is eliminated, so its plasma level drops, leading to a significant improvement in glycemic parameters. So this action is solely glucose dependent and insulin independent. So the risk of hyperglycemia is very minimal. Ultimately, there will be improvement of the insulin sensitivity via several molecular pathways, including the reduction of glucotoxicity and lipotoxicity, enhancement of the beta cell functions, reduce the oxidative damage and inflammatory processes, improvement of caloric depositions, and weight loss. The next one is a glucagon-like peptide 1 receptor analogs. These are also known as the incretins like glucagon-like peptide 1, GLP-1, or glucose-dependent insulinotropic polypeptide GIP, namely liraglutide, dulaglutide, emaglutide, etc. The incretin effect is nothing but the stimulation of glucose-dependent insulin release, particularly following meal injections. There is impaired incretin effect seen in the insulin resistance conditions, and in PCOS women, the incretin hormone levels are low. So, the incretin therapy will cause the glycemic improvement as well as the weight reductions. And when there is a weight reductions, there is chance of the improving insulin sensitivity and ultimately changing of the scenario. So, this way they can help us. Now coming to the few about the drugs in pipeline, that means where the human trial is not yet been done. Like we have discussed about the incretin, so the 2-incretin, that means instead of two separately, when you combine them together, like dual GLP-1 and GIP receptor agonist, so that causes a decrease HbA1c, decrease weight in type 2 diabetes mellitus, so that can be helpful in the PCOS. Same way, dual GLP-1, the glucagon agonist, they also normalizes the glucose tolerance and improve the adiposity and the metabolic parameters. So still this can change the PCOS features also. Triple, that means after seeing these results of the dual one, now again all three have been combined and trying to find out the effect. The triple GLP-1 GIP glucagon agonist, and it has been seen that they have been more effective, causing the weight loss and the decreased plasma glucose and cholesterol. So that means ultimately they can definitely change the biochemical milieu of the PCOS also. Next one in the pipeline is the imeglamines. It is the glucose-guiding agents used for the type 2 diabetes mellitus. Is the oxidative phosphorylation inhibitors, which is a oxidative phosphorylation is a crucial steps in the hepatic gluconeogenesis, and so ultimately it causes the improvement of the glucose homeostasis by improving beta cell function, suppressing gluconeogenesis, lowering insulin resistance, improving mitochondrial functions, and attenuating the oxidative stress. So this also can be helpful in changing the biochemical milieu of the PCOS and ultimately causing improvement. So these drugs, if you use in the futures in the PCOS, definitely the women may be helpful for getting rid of these conditions. So these are my references. Thank you.